Sir, good evening, sir. Can we start?
Yes, we can start.
Good evening, everyone. Thank you for joining with us today. So after a long theory exams, almost we have completed the ENT ophthalmology and community medicine theory exam, and we have a small gap for practical. And in this short period of time, I thank Dr. Vasanth sir, who is with us today and will be there for us for the next 4 days for discussing all the ENT cases as well as the instruments. Thank you so much, sir, for joining with us. I welcome you, sir, and you can take over the session, sir.
Yeah, sure. Thank you so much for the Medusane team. Okay, so hope you had a good time writing your theory exams. The paper from Dr. Thaman MGR Medical University was quite quirky this time, but not a bad one, but it was quite a quirky. You should have a good knowledge to write the theory exam. But anyhow, past is past. So let's concentrate on the clinical discussion part now. Okay, so we'll just go through only the essential things in the clinical discussion of an ear case today. So we are not going to take much of your time, so you can just go through it. I will just give some hints where to how to go about it, and you have to prepare accordingly. I'm not going to elaborately discuss all the answers and the questions here, because it will be really very difficult to make everything in a very short while. Okay, so remember one thing, the examiners don't prepare for the exams. It's only the students who is going to prepare. So the examiners come with an open mind. Just go with the psychology of the examiner. He just wants you to test whether you know some ENT. That's it. Okay, so the examiners will just come ask their own same questions. Most of the time it will be repeated. So the first student will be the scapegoat. The rest of them actually could assess how the examiners are, and those who go in the last of the lot are really very what to say, have to be in a totally in an open mind, because the examiners will be fed up by the time you go and sit in front of them, and they can ask. Most of the time you won't be even presenting the history part, as it happened to me many times, because my name starts with V, and hopefully I go in the last of the last lot. So that happens. Okay, so wherever you are, if you are in the among the first 10, if you are among the second 10, or if you are among the third 10, so you have to set your mind in accordingly before going into the exam. So the examiners usually ask the questions, normally general questions, whatever the questions you had prepared for, because you had prepared for the exam in the last more than a year, I hope, due to this COVID. But what to say, whatever you had read, you had accumulated, it's there in your mind. That's it. Okay, you are not going to prepare overnight today and then going to go for the exam tomorrow. So go with a, what to say, very tender mind. Don't put many facts into your brain or something in the last moment, because whatever you read in the last moment, that stays for long and it keeps rattling in your mind every time. So don't worry about those things. Whatever you had read, whatever you had accumulated, the knowledge in the over the past couple of months is more than enough to pass this clinical discussion. Okay, so going on with that, I think in our Tamil Nadu MGR University, you have the case discussion. You will have a long case and 2 short cases, I think, and OSCE, instruments, osteology, specimens, and slides. OSCE, you have, it's actually very easy to score points in OSCE, because you have to write up to the, what is the question like? If they ask you, oh, what is this? Right, what is that? That's all. Don't elaborate or don't write it in detail. Okay, just write it in points so that you can save time, so that you can go on to the other questions very easily. Okay, and instruments, osteology, specimens, and slides, whatever you're going to prepare for it is more than enough in the last moment, because by the time your case discussion is over, your fate is decided by the time. So whatever the case, if you're going to do well in the long case, then long case and short cases, then OSCE instruments and the OSCE actually adds a point, and instruments osteology doesn't carry a big mark. Okay, so we'll start with each and everything. But actually, we had I think we had a topic on clinical discussion in the year. So I'm not going to cover the whole thing, like starting from the history wise and everything. I'm just going to brush around the important topics and the important questions, whatever which are expected in the exams. Okay, so starting with the otorrhea complaint, you can be asked with the smell of the otorrhea when it is a foul smelling. Foul smell is usually seen in the atticoantral disease or in a secondarily infected tubotympanic disease also. So if you are committing a foul smell, saying that this otorrhea is foul smelling, then be prepared that whether you are dealing with an atticoantral disease or a tubotympanic disease can also have a foul smell when it is secondarily infected. So the examiner will always ask for when you are deviating from the normal history. Okay, so the consistency is also the string sign. Whenever you touch the mucus, and then when you leave it, you makes a string. It forms a string, so that is known as the string sign. Usually, the middle ear is with the goblet cells and with the mucus producing cells are present. Mucosa is present only in the middle ear, not in the external auditory meatus. So any discharge from the external auditory meatus will not have this classical string sign. Only if it is from the middle ear, you have a string sign. So any discharge which is coming out from the middle ear has to have a way to come to the external auditory meatus, and that is where the perforation helps. Okay, unless otherwise there is a tear or a perforation or any break in the tympanic membrane. Unless there is no break, there is no discharge from the middle ear. So if it is a mucoid discharge, if it is having a string sign, then it should be from the middle ear. Remember that. And color of the otorrhea is also very important, and most of the time the examiners will ask this question whether it is blood stained or not. And if you say blood stained, there should be a presence of granulation, and presence of granulation is always in favor of an atticoantral disease, unsafe ear. And the other very common disease which is going to have a blood staining discharge is malignancy. Okay, and watery discharge is only CSF otorrhea will have a watery discharge. So you should, whenever you are saying this watery discharge, beware, you are dealing with only CSF, right? So don't just have the slip of the tongue and just say it is a watery discharge. Say it is a mucoid discharge. Never say it is a watery discharge, because CSF otorrhea is not a case for the exams. Okay, and the quantity, usually the examiners ask how you measure how you classify the quantity of the otorrhea, how you say it is scanty, how you say it is moderate or profuse. It's quite very easy. If it is a profuse, the patient will complain that the discharge is coming out of the external auditory meatus. Sometimes it wets the pillow when the patient is sleeping, or the patient or it can be seen draining out through the external auditory meatus. If it is moderate, it stays within the external auditory meatus, and putting a finger or a small bud cotton bud, you can find the discharge. Scanty is very scanty. It remains only within the external auditory meatus, deep inside. Only on probing with a cotton, then only you get a otorrhea. You can see the otorrhea. So this is how it is classified. So yeah, the otorrhea can be also in the active stage, or it can be during the inactive stage, or in the quiescent stage. Okay, so usually you have a patient with otorrhea, means it is active, so you can see the discharges present. Okay, so the inactive stage is somewhere between 3 to 6 weeks when the discharge has, when the ear is looking dry, and when the again if it gets infected, then it produces the discharge. Okay, so now coming to the deafness. Deafness, you have two types of deafness. While taking the history, you have to give the examiner in a very it should look like a story. There should be no cuts and breaks in between. Okay, you have to flow like a water. The deafness has started so and so the time. We are not going to discuss about those things because you very well know how you are going to take the history. Now I'm not going into that part. So now we are going to discuss only the important questions. So the deafness can be a sudden deafness, or it can be a gradual deafness. Usually in a COM it is a gradual and progressing with time. Sudden deafness, they may ask you what are the causes of sudden deafness. Sudden deafness, usually anything sudden, you just think about the injury or the trauma, temporal bone fractures, or it can be an idiopathic sensory neural, sudden sensory neural hearing loss. And the degree of deafness also, if you are saying it as mild, moderate, or severe, the examiner may ask you how you ask for how you classify this degree of deafness clinically. So clinically, you can classify it like if you are able to converse with the patient in the same distance, in the normal distance as communicating each other, then if you're able to communicate with them, then it is mild amount of deafness. If the patient is not able to hear the conversational voice and you are going to raise the voice, your volume, then it is moderate. And severe deafness is you have to shout aloud, go in near to the patient's ears, and then if you are going to shout, then it is severe. This is a rude, rather than it's a rude way of assessing it clinically, but it makes sense in many of the times while taking the history. And the examiner just wants to ask you how you are going to go about with this. That's why. Okay, so fluctuation of deafness, what are the conditions you have in deafness is Meniere's disease, and in perilimb fistula, you have the deafness which fluctuates here and there. And the other questions which are deafness at the time of discharge. When during deafness, you may have the, during discharging year, the active stage of CSOM, sometimes you have the deafness being very bad and more severe rather than in the dry state. Okay, and what is cholesteatoma hearing? Yeah, this in patients who have a proper cholesteatoma bag which is sitting right over the middle ear and acting as a bridge between the stapes foot plate or the stapes head, stapes bone as such, and the rest of the eroded tympanic membrane. It acts more like a bridge and it conducts the sound. It's due to the cholesteatoma, the patient is going to hear better, actually better. That is what is called cholesteatoma hearing. Okay, so these are the questions you may be asked when you are presenting a case, when you are presenting this complaint of deafness. Okay, the other thing is the diplocues is some irrational examiners you may have one among the four, and who may ask you some different sort of questions, who is very known to be a very quirky guy rather. So he may ask you some syndromes, some sign, and suddenly they will think about something and they will ask you. So those are some added points you may get when they are asking, when you are answering those questions. So diplocues, you might be asked what is a diplocues. It's just hearing the same sound in two pitches in both the ears. Okay, and alteration of deafness can happen in Meniere's disease when during the attacks. So Tumarkin's attack, you call it as, okay. So read those things. These are the simple questions they will be asking you when you are presenting the cases. So when you are presenting vertigo, you can expect what are the causes of vertigo in the ear. So the vertigo in the which is caused due to the inner ear or the ear as such is known as a peripheral vertigo, and the one which is caused by the central nervous system is known as the central vertigo. So usually they have a classical difference with the peripheral vertigo and the central vertigo. What are the peripheral vertigos? The Meniere's disease, the benign paroxysmal positional vertigo, and attico-antral disease when it goes into complications, when it forms a fistula or a sinus over the semicircular canals, it produces vertigo. Vertigo is a sign of complication of a CSOM. Okay, so these are the differences between the peripheral and the central vertigo. So you may, if you are very unlucky, you may fall trap to this question of difference between the peripheral and central vertigo. It's very easily. Peripheral vertigo, imagine it is due to the ear. Central vertigo, it is due to the central nervous system. Okay, central nervous system doesn't start immediately. It's gradually it comes up. Okay, so here the vertigo intensity onset will be gradual, whereas the peripheral vertigo, the BPPV patients will come and say that they got a vertigo immediately once they got up from the bed, once they turn to other side. So it starts as a sudden one. Okay, and the intensity, the one which is sudden will be severe and it stops, lasting for seconds to minutes and it stops. The one which is due to the brain, it is gradual, it is mild, it doesn't stop, it is continuous throughout the day, and the patient will be so much fatigue. Okay, so the nystagmus which is produced here in peripheral vertigo will be rotational nystagmus, whereas in the central it is purely in the unidirectional way. Okay, so with the gaze fixation, when you open the eyes and when you fix an object with the gaze fixation, you can overcome the peripheral vertigo, but the central vertigo doesn't have any significance at all. Okay, and this peripheral vertigo is usually associated with vomiting and nausea. Okay, so these are the differences you should know about between the peripheral and central vertigo. So from Otalgia, what are the signs? Otalgia, you can be asked with a very, it can be a primary Otalgia or it can be a referred Otalgia. A primary Otalgia, you can be asked with a tragal sign. What is a tragal sign and what is 3-point tenderness? And from referred Otalgia, remember 4 T's: tonsil, teeth, tongue, and TM joint. And everything has a separate nerve which separate nerve which supplies the ear also. Okay, so the part of the fifth, the branch of the fifth cranial nerve, the ninth nerve, glossopharyngeal nerve, and part of vagus nerve also supplies the ear. So anything which happens in these areas, you get a referred pain in the ear. So primary otalgia is the otalgia which happens inside the ear. So the tragal sign is positive, classical of otitis externa, and the 3-point tenderness is classical of acute mastoiditis, where you feel the 3-point tenderness, one over the mastoid tip, the other finger over the Simba concha, or otherwise the Simba concha, it denotes the antrum, which is deep inside, and then the third finger over the root of zygoma. So you feel the pain in all the 3 points when you have a typical mastoid infection. Okay. So the next complaint will be of tinnitus. It can be a subjective tinnitus or an objective. Subjective is the patient hears the tinnitus. Objective, even if the examiner also can hear the tinnitus, where it can be a vascular finding. Okay, so whether it is unilateral or bilateral, and sometimes in the other question which can be asked is autophony. Autophony is nothing but excessive loudness of one's own voice in it, which happens in acute separate otitis media, no, otitis media, and also in a patulous eustachian tube. Okay, so the next one is the facial palsy or the facial asymmetry. Facial asymmetry here, this question, whenever if you are asked anything about facial nerve, any discussion on facial nerve, this will be the about the difference between the upper motor neuron facial palsy and the lower motor neuron facial palsy. You have to, what to say, there is no other go, you just ratto this, just mug up this. There is no way you can what to say, get away from this question. When there is a discussion on facial now, you will be asked this one, the difference between the upper motor neuron facial palsy and the lower motor neuron facial palsy. Okay, so once the history part is over, then they come for the examination part, where you can expect the questions on the structures, the landmarks in the of the pinna, the helix, antihelix, the crus, the inferior superior crus and the inferior crus, the tragus and the antitragus, and the lobule. That's it. This is the concha. Okay, so it's very easy. You just go across, see the diagrams also, because the diagrams will help you in answering the OSCE. Okay, in the OSCE you will be given, most of the time you will be given only the diagrams, and from the diagrams you have to the questions are asked for which you have to give the answer. So keep a eye over the diagrams every time you read it. Okay, so then comes the preauricular region, where you have the preauricular sinus and the skin tag or any accessory tragus. If there is a question on preauricular sinus, it can be there. They will be asking you what is a preauricular sinus. Okay, and how you are going to treat it. So it's more just a incision and then excision of the sinus, okay, till the root of it. And then comes the post-auricular region, where you have surgical scar. If you say if there is no such scar, then the next question will be like, you're giving a lead to the question. Okay, what is the name of the incision you give in the post-auricular region? So you have to be well versed with the incision. At least there are only 2-3 incisions in the ear. One is the post-auricular incision, which is known as William Wild's incision, which is usually given because, okay, and the other one is the Lambert incision, which is given in the endoral, for the endoral region. Okay, and then the Greisinger's sign, and Greisinger's sign can be asked you, which is nothing but the due to the thrombosis of the mastoid emissary vein, and then swelling and fistula, anything in the post-auricular region, and obliteration of the groove usually happens when there is a furuncle or when there is a external otitis media, and the ironing of mastoid happens in acute mastoiditis. Okay, so usually this difference between furunclosis and acute otitis media with mastoiditis is very important. Okay, and you have to be very well versed with this. Okay, so many of the old timers examiners, they do ask you about this difference between the furunclosis and acute otitis media with mastoiditis. Okay, here the furunclosis, it's very easy. The boil will be there. Mastoiditis, no boil. And furunclosis is of external ear, so the tympanic membrane will be normal. In mastoiditis, the tympanic membrane will be consistent. Here, the pain will be dull throbbing pain. In mastoiditis, it is deep-seated, so it is sharp piercing pain. And in furunclosis, the hearing will be normal, and in mastoiditis, obviously, the hearing will be altered. And the tragal sign is classical tenderness will be there. Acute mastoiditis will have 3-point tenderness. Here, the post-oral sulcus will be obliterated in furunclosis, but in acute in mastoiditis, it is not obliterated. And here, the pinna is pushed forwards, and and outwards. Here it is pushed forward and outwards and downwards. So the pinna remains at a lower level in acute otitis media. Okay, so when you go to the external auditory meatus, the questions you can expect are about the wax, the fungus, the functions of what is the function of the wax, what is the composition of the wax. Okay, and then the fungus, what are the various fungus which can go infect in the external auditory meatus, and what is collateral fistula, what is exostosis, what is swimmer's ears, Singapore ear. Okay, what is keratosis obturans and how you are going to treat it. Malignant otitis externa is more a theoretical question, but watch out for sometimes in the clinical part. And fissure of Santorini, you should be able to say what is it. Okay, and then comes the tympanic membrane, where you have to say the landmarks. Okay, beware of the normal landmarks, the lateral process of the malleus, the umbo, and through this straight line is drawn, and this one is posterior and this is the anterior half, and 90-degree line that goes through the umbo, divides it into the superior and the inferior. Then you get 4 quadrants here. Okay, and this is pars tensa and this is pars flaccida. Okay, so it is very important. The cone of light is formed in the antero-inferior quadrant. Okay, and there you may be asked a question about where you insert the grommet. Okay, what is the incision for inserting the grommet? It can be, so it is a linear incision, okay, along the fibers of the pars tensa, so that once the grommet is retrieved, the healing is good. Okay, the grommet is usually done in the antero-inferior quadrant. Okay, and then comes the perforation, the central perforation, which is surrounded by pars tensa on all sides. Marginal perforation, where a part of the margin of the perforation is formed by the bone. Okay, external auditory meatus bone, and the attic, any perforation in the attic can also be there. Marginal perforation is an unsafe ear. Remember, it's not a safe ear. Okay, then the test of eustachian tube patency. Okay, Valsalva, Toynbee. At least try to mention the name of the test. Okay, even though if you don't know how to go about it, just mention at least, so that they will understand that you had read. Okay, there are if you are not able to explain how the test is done, or it doesn't matter, at least if you say the name of the test, they will be very happy. Okay, Valsalva maneuver, okay, Toynbee maneuver, Politz's test, and ET catheterization. These are the tests to do the check the patency of the eustachian tube. The fistula test is usually done with the finger pressing the tragus to give a positive and a negative pressure. It can be done with the Siegel's speculum also. When the fistula is present, when there is a fistula and the fistula sign is also positive, then it is a positive fistula test, which is present in cholesteatoma. Okay, if the fistula is absent, there is no fistula which is there, but you get a positive fistula sign, which is false positive test, which happens in congenital syphilis, which is also known as Henneberg's sign. Okay, so the fistula is present, but the fistula sign is negative. We don't get a positive fistula, then it means it is a false negative, then it is a dead ear. Okay, so these are very specific tests. Fistula test can be asked, because you would be saying that fistula test negative or positive, then they may ask you how you did the fistula test, and be prepared, don't panic, and if they ask you how you did it, just explain how you did that test. Okay, so the examination of the facial nerve, they will ask you how you are going to how you examine the facial nerve. So you should say that I ask the patient to raise the eyebrows, close the eyes tightly, whistle, blow the cheek, look up, to wrinkle the forehead, and so many things are there. Okay, so these are also the questions that can be asked. And tuning fork test, we have a we had a big presentation over the tuning fork test about all the tests, but the major tests are the Rennie's test, Weber test, and the absolute bone conduction test, which is very, very mandatory for you to do at the time of the examination and to write it. Okay, so write whether the Rennie is positive and whether the Rennie is negative, and Weber's test to which side it is deviating, and absolute bone conduction test also. Okay, so you don't do any mistakes in doing this tuning fork test. It is very, very easy. Okay, any CSOEM is the case is there. If there is a perforation, there will be a deafness. So Rennie's test is usually done with 5-1-12. If you asked which tuning fork you used, you can say that it is 512 hertz tuning fork, because there are various reasons, 3-4 reasons for that, because it lies in the speech frequency, and there are no overtones, and the decaying time is also more. Okay, so Rennie's test, Weber's test, and absolute bone conduction test are very, very essential. You have practice it with your colleague before going for the clinicals. There is no harm. Both of you practice well, because you guys will be having a group study. Okay, so before going for the exam, practice it and then go. Okay, don't mess up with the tuning fork test. It is easy and you can easily score your points there. And coming to the diagnosis, your diagnosis should be complete. If it is a chronic suppurative otitis media, mention the side, mention the type, whether it is tubotympanic or atticoantral, and then this one is very important, with or without complications. If it is with complication, then you should mention what type of complication, whether it is intracranial or a intracranial or intratemporal complication. Okay, you should mention that. But most of the time you will be given a case without complication, because any case with complication, they won't be allowing him to sit inside the exam hall for long. So you will get a case only without a complication. So whenever but don't go with that mind. Just if at all, if you find any complication signs, then you just jot it down and then work it out. Okay, don't just go in a prefixed idea that this is not going to happen. We will get this type of cases and those type of cases. And don't get carried away with your friend's opinion on the findings. Whatever the findings you see, you write it, because most of the time you will be correct. 90% you will be correct, rather than, but most of the time you see the friend's one and then you correct it and land up in trouble. Okay, so whatever you find, whatever you see, you write it. That is the better one. Okay, so in the investigation part, you might be asked about the Sculler's view. The Sculler's view will also come in the X-ray part, and here you may get what are the types of pneumatization of the mastoid, the 3 types of cellular diploid sclerotic, and what is McEwen's triangle, and what is its significance, what are the boundaries of McEwen's triangle. So read about it. The significance is McEwen's triangle is the landmark of mastoid antrum. So we start drilling here so that we can reach the antrum. Okay, so we take the X-ray to assess the tegment plate and to assess the mastoid cavity. I mean the mastoid pneumatization. Okay, so the audiometry, I just included it because you may get it in the OSCE, so that you should not have a blank look at that time. So here you have the decibel levels. Okay, here you have the frequency levels, and with till 25 it is normal. So 25 to 40 it is mild. 40 just 25 to add 20 add 15 you will get it. 25 to 40 is mild, 40 to 55 is moderate, 55 to 70 is moderate to severe, 70 to 90 it is severe, and above 90 decibel is profound hearing loss. And this is the red for right. Have the remember that. So this is the right ear and this is the left ear. The left ear we find it as normal air conduction, and in the right ear the air conduction is way below. Okay, so this says that the right ear air conduction is less. Here this is the bone conduction part which is measured. Okay, and this is here you can see the air conduction and the bore conduction or go along with each other with a very minimal airborne gap. So anything less than 10 decibel between the air conduction and bone conduction, that is normal. Okay, here you find a big gap. Okay, so it's more than 1 2 3 4, so it is more than a 40 decibel airborne gap you have. So this is, if you have a airborne gap, if you have a distance between the bone conduction and the air conduction, then it means that it is a conductive hearing loss. If both the air conduction and the bone conduction are below here, then it means it's a sensory neural hearing loss. Okay, so here you can find both the air conduction and bone conduction are below, so we find a sensory neural hearing loss. What are the other questions you might be asked is in audiometry is it might be an acoustic notch where it happens, and Carrot's notch where it how it happens, and what is the pathology in which it happens. Okay, Carrot's notch is nothing but a 2K dip, a dip in the bone conduction, a dip in the bone conduction at 2000 hertz. Okay, so that is Carrot's notch, which occurs in otosclerosis. Acoustic notch happens in the air conduction part at 4K, 4000. There is a strong dip here in the 4000 hertz. Okay. And once you mention about the surgery, you should be well versed with the tympanoplasty. What are the types of tympanoplasty? Okay, type 1, type 2, type 3, type 4, type 5. Okay, and then what is a meringoplasty and what is the surgery you are going to do for this case actually. So you have to be, if it is a plain simple perforation which is dry, then you can, it's a small perforation, then you can go for saying a meringoplasty alone. But if it is a perforation of a long-standing duration, or if it is an artichoantral disease, then if it is a perforation with a long-standing duration which was having an amount of discharging ear, then you can say that you can go for a cortical mastoidectomy also. Okay, and if it is a artichoantral disease, then you have to say you go for a modified radical mastoidectomy or MRM. Okay, so you should be you should know for which disease you have to give what surgery. Okay, and once you say the surgery, then you might be asked many questions in and around surgery only, like landmarks of facial nerve in surgery, and what is spina fenley, what is short process is cochleariform is, and what is the significance of chorda tympani. But don't go into these things, because if you had read it, okay, well and fine, but just know what are the landmarks in surgery which is used to locate the facial nerve. Okay, and what are the complications of surgery? As already we had discussed those things, as the complications are per-op complications and the immediate and the late complications. Immediate complications, what are mostly associated with the injuries of the nearby structures. In ear, the most dreaded injury is the facial nerve injury. Okay, so the rest are bleeding and so on. So injury to the sigmoid plate or injury to the lateral semicircular canal. Okay, so these are the injuries which can happen, which are immediate and inside the pero. In the late complication, it can be a secondarily infected. The graft may have a failure. The ossiculoplasty, whatever you did, might go what is it, might not have a good hearing. So those are the other things where you can go into the elaborate. And so remember, have a clean mind, what to say, just once the examiner asks the question, take some time and then try to answer it. Okay, don't be in a hurry to say whatever you know. Okay, so the other topics here, coming to the end of it, actually the other topics what you have to study before going for the clinicals is the stages of the ASOM, what is OME and what is the treatment of it, grommet, what is the indications of the grommet and what are the types of grommet and where you are going to place the grommet, and most important one is the complications of CSOM. Is very 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 important question. Okay, everyone is going, any examiner will ask you complication of CSOM. Okay, and the signs of intracranial complications and test like the Brudzinski sign and the Koenig sign. These are the things they will be asking. So for the CSOM, the whole, you have to read the topic as such. You have to mug it up like anything from Dingra. Okay, and but the other topics might be of presbyocusis, acoustic trauma. Even if you don't know about these topics, it doesn't matter. But if you doesn't know about the definition of cholesteatoma, if you don't know about the complications of CSOM, then you are going to cut a really a sorry figure in front of the examiner. Okay, and impedance audiometry, just see the diagrams. What is the normal curve, what is AS curve, what is the C type curve, what is a B type curve, and what is a AD curve. Only 4 curves you have, and what each one has a specific pathology. You might be getting it in your OSCE. Okay, just sharing some images. This is nothing but the bubbles inside, air bubbles inside the fluid level, which is the OME, otitis media with effusion. This can be asked like in ASCII, where you have to name the landmarks of the pinna here, and here the inner ear structures. Okay, and the other instruments, if you know the instruments, you say the name of the instrument. If it doesn't know the name of the instrument, at least say what is the instrument. Okay, so this is the ear speculum, and this is the Jobson horn ear probe with a cotton wool carrier and a curette here, ring curette. This is the mastoid retractor. This is the Hartmann forceps of ear, which is most of the time used to remove the foreign body of the ear. And there are many instruments used, but just go through. If you are not able to remember what is, like, if it is a Jobson horn, if you don't know that Jobson horn, just say this is a ring curette ear probe with a ring curette and a cotton wool carrier. At least try to say that one. Okay, at least if you say this as a forceps, you might end up saving your skin rather than cutting a sorry figure there. Okay, so I hope you people might have gone through, you might have read proper, what to say, in depth, but don't get panic. Have a good sleep, and then go with an open mind and try to correlate everything. Just think about it. If this is that and that is this, what is it? Okay, don't go in a prefixed mind or in a other type, what to say, in a confused state. Okay, do your exams well. Don't try to get influenced by your friends. Okay, you go with your findings. Okay, if you are okay with your findings, if you are confident in your findings, go with it. Okay, unless you don't know the findings, then you can ask others. Otherwise, if you know the finding, you just write whatever you had seen. Okay, so go with the open mind. The examiner is going to check whether you have no ENT or not. That's it. Okay, because this is not a post-graduation exam where you're going to deal with ENT day in and day out. And so they just want to know how far you had studied ENT, whether you had studied some ENT or not. So whatever you know, the examiner is going to ask you whatever you know. It is just that you have to answer in a proper manner. So do well with your clinics. We'll come up with the next case discussion. Actually, I had very less time preparing for this one. For the next case discussion, I think we will go even in a detailed manner. Okay. Thank you for your time and all the best for your exams. Thank you. Balaji, it's mute for you.
Oh, sorry. Thank you so much, sir, for joining with us today. Actually, we had very short period of time. So I hope he has covered every topic in this. And thank you so much, sir, because today we had very less time for you because we informed only 2 days or 3 days prior. And you just made a fantastic session today, sir. Thank you so much. And tomorrow, let's get together again, sir. Thank you. Thank you, sir.